All right, everyone. I think we're about at that time now. Hope everybody can hear me okay. This is Tim Small, Director of Sales at PRN, and we thank all of you for coming out and joining us tonight for our webinar. This is actually the first in the February series. Tonight we're going to be talking about understanding diabetes mellitus and diabetic retinopathy. And we're really fortunate to have Dr. Mitchell Feynman coming back and joining us again for this presentation. Dr. Feynman is going to be leading the lecture tonight. And as usual, because of the number of people that are going to be in the line with us, we've muted everybody's phones. So if there are any questions that come over throughout the presentation, you should see a little toolbar on the right-hand side of your screen. There's a chat icon there. Feel free to chat your questions over throughout the presentation. We'll have our presenters address them at the end. Again, the way that the course will follow tonight, Dr. Feynman will be leading things off. We'll also have Dr. Michael Gross, PRN's Chief Medical Officer, following up Dr. Feynman, and I'll be concluding the presentation tonight with the last 5 or so minutes. So feel free again to chat your questions over, and without further ado, we're going to kick things off and have Dr. Feynman begin.
Thank you, Tim. It's a pleasure to be here this evening. I'm going to be speaking about diabetes mellitus, a condition we all know very well from the office. And I'm going to break it down into discussing how the diagnosis is made, how it's classified, and the risk factors for diabetes. And then for those who have diabetes, diabetic retinopathy progression and how it can be slowed or halted. And then finally, for those who have diabetic macular edema as a manifestation of their diabetic retinopathy, how that can be managed better. Why is this important? Well, diabetes affects 29 million Americans, and most of these cases are the type 2 diabetes. It is the 7th leading cause of death in the United States as of 2013, and it's the leading cause of kidney failure, lower limb amputations, and of course blindness. It accounts for more than 20% of our healthcare spending, an enormous number. Now, the risk factors are well known. People who are overweight, over the age of 45, if you have a family history of type 2 diabetes, or if you're inactive physically, less than 3 times a week. For those women who had gestational diabetes or delivered a baby weighing greater than 9 pounds, they're also at a higher risk. Now, the number and percentage of people with diabetes in the U.S. is going up dramatically over the last several decades. And that can be correlated with the epidemic of obesity. So as you can see on the top row, the incidence, actually the prevalence, of obesity has been increasing over the last 2 decades. And it, as of 2014, over a quarter of the population in most states are clinically obese. And you can see very clearly on the row below that the incidence and prevalence of diabetes has been following right along with the prevalence of obesity. So this is a weight problem primarily. The bigger issue that we have to deal with in the future is that there's a condition called prediabetes that affects 86 million Americans, it's estimated. And almost all of these people who have prediabetes are not even aware they have it. And if the conditions continue, about 1 in 3 adults in the United States could end up with diabetes by 2050 if nothing is done. So what is prediabetes? Let's start there. Well, if you have a fasting blood glucose less than 100 milligrams per deciliter, that's normal. But anywhere above 100 and less than 126 is considered impaired fasting glucose or prediabetes. And this, by the way, these intervals are changing, so you need to keep up with the literature because these have changed even since I've been in medical school. If you take a 2-hour plasma glucose, oral glucose tolerance test after consuming glucose, if your levels are less than 140, that's normal, but if you're between 140 and 200, you have prediabetes. And finally, as most of you are well aware, hemoglobin A1C, and this is the number that's really changed over the years, the threshold has gone down for having prediabetes. So normal is now less than 5.7%. But anything above 5.7 and less than 6.5 is called prediabetes now. If you're above 6.5%, you have diabetes. And of course, this is not one reading. This needs to be taken on 1 or 2 occasions to confirm. But it is important because once you have diabetes, obviously the risk of blindness goes up considerably. So pre-diabetes is an important risk factor for future diabetes development, which then leads to cardiovascular risk. And it's a continuum. So if you can identify patients at risk early and you can begin the interventions immediately, you can actually reduce the rate, and this has been shown in studies, from progressing from pre-diabetes to diabetes. And all of you know the therapy that's been recommended, healthy diet, and that definition of a healthy diet, as we were discussing before this webinar, keeps changing, whether it's low fat, low carb, whole food diet. But we know that a healthy diet consists of non-processed foods at the least, and the consumption of lean meats and vegetables. Physical activity at least 3 times a week, and that doesn't have to include vigorous activity, that just has to include things like walking and basically losing that sedentary lifestyle. And both of those, diet and physical activity, can lead to weight loss, which is again linked very closely with the development of diabetes, as I've showed in those obesity prevalence slides. So the risk factors for diabetes that are not modifiable, the age, the race, gender, family history, of course we can't do anything about. But what we can modify are the things we just discussed. Increase physical activity, lose weight, control hypertension, stop smoking. High plasma glucose levels are, of course, a hallmark of the diabetes. But we also see here abnormal lipid metabolism, which is also a risk factor for the development of diabetes. And we know that abnormal lipid metabolism exists in diabetic patients. And this is a study from the American Journal of Gastroenterology that looked at patients with diabetes, and they note that a significant proportion of diabetic patients have a deficit of exocrine function. So this exocrine pancreatic insufficiency makes it more difficult for diabetic individuals to absorb fats properly and in proper proportions, and especially those patients who have excess weight or a high BMI, they're at much more risk. In addition, we know that lipid metabolism is compromised in diabetic patients. Not only that, we know that abnormal lipid metabolism, or dyslipidemia, is involved in the development of diabetic retinopathy. What we don't know, though, is whether interventions such as statin therapy or other interventions can affect the natural course of that. But obviously, if you can use diet and other natural means to correct dyslipidemia, it certainly isn't going to hurt and will possibly help your diabetic patients avoid complications. So I'm going to spend a little time now discussing omega-3s for patients who are at risk for diabetes mellitus. An article in Diabetes Care showed that patients who consumed a higher amount of omega-3 fatty acids, and this is a study that was done in over 2,000 Finnish men, the Kuopio Ischemic Heart Disease Risk Factor Study. They looked at the circulating levels of serum omega-3 in the blood of these men, and they looked at it over a long period. And what they found was that those subjects enrolled in this study that had a higher level of omega-3 in their blood had a lower long-term risk of type 2 diabetes over a 20-year period. And so if you looked at the people with the highest levels in their blood in that quartile versus the ones with the lowest levels of the omega-3s, the highest level had a 1/3 lower risk for developing type 2 diabetes. The other important finding that came out of this study was that eating fish, whether it's large or small amounts alone, wasn't directly associated with this reduction in risk. The fat from the fish had to be absorbed and circulating in the blood to have that effect. So again, we see how the lipid metabolism can affect the ability of these patients to absorb the fats So fish alone was not effective in reducing the risk, but those who were able to absorb the omega-3 and had higher circulating blood levels enjoyed the protective effect of the omega-3 levels. So what about patients who already have diabetes and they're at risk for diabetic retinopathy? What is the role for omega-3s in these patients? Well, we know that the diabetic retinopathy risk factors are as follows. By far, the most influential is the duration of the diabetes. So if you have diabetes mellitus for a long time, especially over 20 years, you're much more likely to have it than someone who's had it for less. But those people who have poor control of their blood sugar have an accelerated progression of diabetic retinopathy. And other systemic medical issues, such as high blood pressure, high cholesterol, high triglycerides. Again, you see the dyslipidemia at play here. And tobacco use also have higher risk factors for diabetic retinopathy. And we also know that in pregnant women with diabetes, they can have an accelerated form of diabetic retinopathy during the pregnancy because of hormonal levels. Now, we all know how devastating diabetic retinopathy can be on the eye. Those people who develop retinopathy have a much higher risk of developing macular edema, vitreous hemorrhage, loss of vision. In fact, as far as vision loss goes, 12% of all new cases of blindness annually in the United States are due to diabetic retinopathy, and it's the leading cause of blindness in patients less than 75 years of age. So this is something we'd like to prevent if possible. So is there evidence that the omega-3s can prevent diabetic retinopathy, or at least slow it down in patients who have diagnosed diabetes? In fact, there is. People who ingested a low glycemic index diet, so low simple carbohydrates, along with omega-3 fatty acid supplements, were found in this study to have a protective effect where they had decreased significant levels of hemoglobin A1C as well as C-reactive protein, a nonspecific indicator of inflammation in the body. So these people simply changed their diet, added an omega-3 supplement, and found improved systemic control. So we know that this can be effective. What about people who have diabetic retinopathy and we're trying to slow the progression? Is there any role for omega-3s in that? Well, when we look at the severity of diabetic retinopathy for people who are newly diagnosed with diabetes, they usually present with no apparent retinopathy, and this could last for years. But once they develop diabetic retinopathy, beginning with mild non-proliferative diabetic retinopathy manifested by microaneurysms, which then progress through moderate and severe, and we all know the 4-2-1 rule, with 4 quadrants of hemorrhages, 2 of venous beating, or 1 of IRMA, intraretinal microvascular abnormalities. They have severe non-proliferative diabetic retinopathy and are at higher risk for vision loss and progression to proliferative diabetic retinopathy, which is manifested by neovascularization, whether that's the disc, retina, iris, or angle. And the neovascularization can lead to vitreous hemorrhage or worse, traction, retinal detachment, and scarring. So anything we can do to slow this progression would be helpful. Well, in JAMA Ophthalmology last year, there was a sub-study from the Primary Prevention of Cardiovascular Disease with a Mediterranean Diet, the PREDIMED trial. And what the PREDIMED trial looked at was subjects enrolled in a trial in Spain over a 6-year median follow-up period. And these people had type 2 diabetes, and they were older individuals. And what they found was that those subjects enrolled in the study that consumed more than 500 milligrams per day of fish-derived omega-3 fatty acids, when compared to those that consumed less than 500 milligrams, and this was a critical level, the 500 milligram was the cutoff. So if you compared those two groups, the folks who consumed greater than 500 milligrams per day of fish-derived, marine-based, this does not include flaxseed or chia seeds or other vegetarian sources of omega-3. That is not the same as omega-3 from fatty fish sources. Those subjects enjoyed an almost 50% relative reduction in the risk of sight-threatening diabetic retinopathy. And this translates to about 2 weekly servings of an oily fish. The authors concluded that the results of this study concurred with other findings from experimental models and the current model of diabetic retinopathy pathogenesis, whereby the protective effect of these omega-3s and their anti-inflammatory effects slowed the progression of diabetic retinopathy. So this PREDIMED study was really a very sentinel article as far as what we know about how effective omega-3 intake can be in preventing diabetic retinopathy progression. So previous studies have shown a protective role of supplemental DHA or omega-3. This study confirms that the 500 milligram per day dosing of omega-3 decreased sight-threatening diabetic retinopathy. So the authors recommended that patients who are older with type 2 diabetes meet a target of at least 500 milligrams per day of dietary omega-3 fatty acids. And that's what I agree with and recommend as well to my patients. So what about patients who've already passed that point and they've developed diabetic macular edema and they're receiving anti-VEGF therapy either with Lucentis 0.3 milligrams or Eylea? Can or Avastin, I should add. Can omega-3s benefit this subset of patients? Well, there's an article in Retina where the authors looked at patients with type 2 diabetes and center-involving diabetic macular edema. This was a 2-year study, and all of these patients, all of the subjects were receiving Lucentis for diabetic macular edema. And what the authors did is they randomized half of the eyes to receive additional DHA supplementation, a little bit over a gram of DHA and about 125 milligrams of EPA, in addition to the anti-VEGF therapy. And what they found is illustrated in these graphs. On graph left, the lighter colored line, the lighter gray, is the control group. These are people who were receiving ranibizumab alone. And then the darker line was the ranibizumab plus the DHA supplementation. And what you see is an earlier and more dramatic decrease in the central macular thickness on OCT. And that early improvement was sustained throughout the 2 years of the study, and those patients maintained that decreased central macular thickness. Now, the graph right shows the ETDRS visual acuity, and similarly we see the darker line, the DHA supplementation plus the anti-VEGF therapy had an earlier and more pronounced improvement in vision compared to the control group receiving injections alone. Now, I will point out that the statistical significance did not reach critical level in the slide, in the graph to the right. However, the central macular thickness did. So the authors concluded that the ranibizumab plus the DHA supplementation reduced central subfield macular thickness compared with ranibizumab alone, and this was statistically significant. And that the anatomic improvement by OCT was accompanied by a trend for an improvement in vision, although, as I mentioned, this was not statistically significant based on the number of subjects in the study. So what could be the mechanism whereby the addition of DHA or omega-3 might help improve central foveal thickness by OCT and maybe improve vision? Well, we may get some insight based on a study which looked at patients with macular degeneration. And this was a very interesting study. We have 4 groups. The control group, all the way on the far left column, shows the normal standard basal rates of vitreous vascular endothelial growth factor. And the next column to the right of that, the naive group, shows the vitreous VEGF levels in patients who have not undergone treatment yet, but have wet AMD. Not surprisingly, they have much higher VEGF levels. I mean, that is one of the main stimulators of neovascularization. Now, in the patients receiving anti-VEGF therapy, that's group 3, the column to the right of that, the anti-VEGF group, they have a reduction, expected reduction in their VEGF levels. They're, of course, receiving anti-VEGF therapy, whose goal is to reduce VEGF levels. So you can see the reduction. But the really dramatic column on the right shows what happens when the anti-VEGF is supplemented with omega-3. You can see not only is there a reduction in the VEGF levels in that group, but it is superior and statistically significantly better than anti-VEGF alone when you add the omega-3. Now, admittedly, this is a study in AMD, but I think the take-home message here is that anti-VEGF therapy does affect VEGF levels in the vitreous, and we see that from this study. It's very simple to extrapolate that this effect may be at least partly responsible for the effect we see in diabetic patients receiving anti-VEGF therapy, and certainly wouldn't be harmful for all patients with diabetes with elevated VEGF levels to benefit from that type of effect. So the authors concluded in this study that omega-3 supplementation, when combined with anti-VEGF treatment, is associated with a decreased VEGF level in wet AMD patients. So in summary, I think what I've presented tonight supports the concept that omega-3s are beneficial for diabetic patients, really at all stages. We know that DHA supports retinal cellular metabolism, structure, and function, and omega-3s, specifically the high DHA, can help to delay the onset and slow the progression of diabetic retinopathy. The mechanism may include that the omega-3s assist in the suppression of retinal inflammation, which may be playing a role in the pathology of this disease, and that a minimum of 500 milligrams a day of these omega-3s in one study provided an almost 50% reduction in the risk of sight-threatening diabetic retinopathy. That's an enormous benefit. So in summary, what I've hopefully laid out in a very clear and concise manner is that as far as pre-diabetes and diabetes making the diagnosis, that diet, exercise, and weight loss remain the mainstays of our treatment for this, but that omega-3 supplementation may play a role in reducing the progression of pre-diabetes to diabetes or delaying the diagnosis of that disease. In people who already have diabetic retinopathy, risk factor reduction and metabolic control remain the mainstay. We know that newer studies show anti-VEGF therapy can slow the progression of diabetic retinopathy, but that requires an intravitreal injection, obviously invasive procedure. The PREDIMED study suggested that omega-3 supplementation in this group of patients may slow the progression of diabetic retinopathy. And finally, for those patients who are already receiving anti-VEGF therapy for diabetic macular edema, or intravitreal steroids for diabetic macular edema, or even macular laser, that the addition of omega-3 supplements to this group of patients may reduce intravitreal VEGF levels and may help improve the OCT thickness, and in one study showed a trend toward better vision in the group that was supplemented with omega-3, specifically DHA. I thank you for your attention.
All right, great. Well, thank you so much, Dr. Fiman. And again, please feel free to chat your questions over as we move on to the next part of our presentation tonight. So now that Dr. Fiman's been able to provide all of you with a clinical background on our discussion tonight, I'm going to pass the baton over now to Dr. Michael Gross, PRN's Chief Medical Officer, to talk with you about PRN's new solution for how you can address this condition in your office and what makes this solution so unique to anything else that's out there on the market today. And very quickly, you'll get a little cap on exactly who Dr. Michael Gross is.
Well, thanks, Tim, and thanks to all of you for joining us tonight. A shout out to our incredible account management team for filling all the seats again, and this topic seems to be resonating very strongly with all of you, as I think this is our 5th or 6th rendition, and it's been pretty much standing room only. So thank you all once again for your participation, and what a thrill it is always to be following Dr. Mitchell Feynman, who's already in that rarefied air of retinal specialists, and in this case from Wills Eye Hospital, Wills Eye Institute. But even more relevant in this case is that Dr. Feynman also has training in nutrition. So all of our retinal products have been done in conjunction with Dr. Feynman, and his participation in both the formulation and the concepts of our products have been invaluable and have helped make what we think are the best of breed products in this regard. So you're about to hear about a new product, and again, tremendous gratitude to Dr. Feynman for helping us collect the data that supports this product. But before I go there, you just heard about at least one of the epidemics of the 21st century, and it is the type 2 or insulin-resistant diabetic epidemic that follows the obesity epidemic. And there is a responsibility now that's been given to physicians, and that is we have to screen these patients on a regular basis. For as long as it lasts, the Affordable Care Act requires that recently diagnosed type 2 diabetics have an annual eye exam. So this is a huge cadre of people that need to be evaluated. And unfortunately, the very reason that they're there sitting in front of you is because they've had difficulty with lifestyle, with diet, with exercise, and so forth. And the only tool that you have to offer them is a better diet and a better lifestyle. But we now have something else that we can offer in addition to that, that is truly evidence-based. But here's a spread of the type of exposure that you are getting to these people. 3 to 5 patients a day or more, 15 to 25 a week or more. So this is a huge group of patients, and the population is growing exponentially. So you see we have approximately 30 million that are diagnosed or in a diabetic stage but undiagnosed, and another 80-some million in the queue. This is a huge problem, and we have to ameliorate this as best we can, and you're going to hear about an intervention through a medical food that will help them considerably. So in recognition of the fact that over time, just about all of these folks will develop retinopathy. Of course, if they're type 1s, that means they probably had it from childbirth or from childhood, and all of these folks will ultimately develop retinopathy. That's the bottom line on this slide. But over 60% of these people will develop it within 20 years, and about 40% in 5 years or less. So we've really got to help them, hopefully, before this becomes a sight-threatening issue, and that involves diet and lifestyle, and hopefully another intervention, which we're about to introduce to you, supported by the evidence that Dr. Feynman just provided. And that evidence is DHA, omega-3, based on these studies, wherever they are in the progression or evolution of this disease. Giving them DHA with a small amount of EPA will help either reduce the onset, or if they have some of it already, slow the progression of this disease. But important to remember, whenever they appear in front of you, you can help them with an appropriate dose and form of an omega-3 essential fatty acids. And why is this so critical in the diabetic population? I'm about to explain to you, but please understand that this is the only medical food specifically formulated for this problem, the particular problem of reducing the onset and the progression of diabetic retinopathy. You've heard the clinical evidence, and these folks need more than just fish, as you've heard. They need something additionally, because their ability to digest, absorb, and process fats is compromised by their diabetes. We all know about the endocrine form of diabetes and its effect on insulin production and sensitivity, but these folks also have an exocrine form of diabetes. They do not make digestive enzymes well, and that includes lipases, so their fat metabolism, their lipid metabolism, as you heard from Dr. Feynman, is compromised, which is why they need additional omega-3 fatty acids alongside of whatever else they might be getting in their food. And here is the 1,200 milligrams that you saw from that last study in the same ratio as the study that involved Lucentis. And it is in the form that these people can easily digest, absorb, and process. And it is a medical food. And that's not just a throwaway category. That is meaningful. But most of us, surprisingly, or maybe not so surprisingly, haven't heard much about the category of medical foods. So you really have to qualify to be a medical food, similar to being a drug, except the Food and Drug Administration is a little less vigilant about this. You don't have to go through an approval process at the outset. They usually show up afterwards. So we at PRN always believe that we should have the evidence to support any product before we launch it. And a medical food is actually something that was born from the Orphan Drug Act of 1983. And that was an acknowledgement by the FDA that there were actually some diseases that could be better impacted, ameliorated, or controlled by foods, but not foods in a regular diet. In other words, you can't just eat your way out of this disease, and it has to be a specific disease and under the control of a physician. So for principle number one of a medical food, you can't eat your way out of this with a normal diet. You need something specific that's found in food in order to accomplish your goal therapeutically. It must be managed by a physician. So you're not going to see this on Amazon or in GNC or Whole Foods or whatever. This is totally under your control, and it qualifies in that regard to be almost as high a level therapeutically as a pharmaceutical. It must be proven in terms of evidence and efficacy, and you just heard that. And as a result, we can talk about medical foods in terms of disease claims. And you just heard something that I want to emphasize again. To delay the onset and progression of diabetic retinopathy, that's a very big deal. So at PRN, we've always tried to make our folks, our partners, understand that all forms of omega-3 are not created equal, and that the forms that people buy that are called fish oils out there, they're chemicals for the most part, poorly absorbed, causing all sorts of digestive havoc, because in chemical form, our body doesn't recognize them. It's not like eating a fish. You're eating some chemical derivative of the purification process of that fish, and as a result, burping and indigestion and a lot of other things occur, but that doesn't happen when you eat fish. So be forewarned that any product that's called a fish oil or an omega-3 that has an enteric coating around it is something that has a lousy substance inside of it. I don't think your last piece of fish was surrounded by an enteric coating. It just means that it's difficult to digest or absorb and causes havoc. Therefore, it needs to be coated, and that makes it even less effective and absorbable. So this is the seminal study in terms of bioavailability and absorption. You've seen it before in other contexts. It was done by Dr. Jordan Dyerberg, the real father of omega-3s, presently nominated for a Nobel Prize for his work. The baseline is fish oil itself, raw fish oil, what you get when you eat fish, but that means you're getting that raw fish oil, and it's exactly what the fish was exposed to in its lifespan, and that includes mercury, PCBs, dioxins, and what have you. So I don't think that you want that either, but you can see even in that raw form, often called native oil in the stores, it's still more absorbable than the usual form that's sold, ethyl esters. But when you recreate, I like using that small r in terms of the RTG form in a number of ways, recreate, reconstitute, it actually means chemically reesterified. But when you've recreated Mother Nature's form, you've put the omega-3 back into the triglyceride form that's found in food without the chemical contamination. Thus, it becomes the most highly absorbable form. Now, your patients who are recently diagnosed with diabetes, no matter what else they now have an additional problem of exocrine dysfunction, abnormal lipid metabolism, abnormal fat absorption, digestion, and processing. So they need a booster of omega-3 in this form, at least a gram or more, as you've just seen. They cannot eat their way out of this with a normal diet, and we have the most highly absorbable form in the reconstituted or reesterified triglyceride form. This is how human beings were exposed to omega-3s through our evolutionary journey. We didn't eat krill. We foraged for a while, so plant omega-3s worked for us when we were in that phase of our development. But ultimately, we figured out how to catch up to the fish and eat them. And that's why we need omega-3s from marine sources. Fish sources work best for humans. So here is our product that we're so proud of, a medical food which we call New Retin, based on the evidence that you've just heard, qualifying for the title and the imprimatur of medical food. And here's where I get a little uncomfortable. I am a maternal fetal medicine specialist with some degrees in nutrition. I am not an eye care specialist like you all are. So it's difficult for me to tell you all how best to communicate with your patients in this regard. We're hoping now that the product is just about to be launched that we'll have some feedback from you all, you practitioners, and you can help us understand the best messaging that can be provided so these folks understand and utilize what is an incredibly meaningful tool for their diabetic disease. But some suggestions, and based on the evidence that we have, New Retin is a nutritional approach to delay the onset and slow the progression of diabetic retinopathy. I recommend that you begin taking this every day. This is an everyday solution. The eye and the retina in particular has a high percentage of essential fatty acids. The eye and the brain are very similar in structure and function. DHA is the predominant omega-3 in the retina and in the brain, although there is some EPA there. And as an essential nutrient, your body cannot make or store this. You can only get this from food. And because you have diabetes, your ability to digest, absorb, and process fats is compromised. You need a booster of DHA and a little bit of EPA to help ameliorate this disease. And it's in a form that you can absorb in spite of the compromise of your exocrine pancreas. And as you have just heard now for a number of times, it will slow the onset and progression of diabetic retinopathy. So for your recently diagnosed patients, this is an essential nutrient which can have as much as a 50% reduction in sight-threatening diabetic retinopathy. And as I just showed you, 38% of folks recently diagnosed will be in this category. So we need to get to them and help them as quickly as we can. And it's something that all patients should get. The capsules are smaller than some of our previous products, easy to swallow, 2 a day, and they need this in addition to whatever else they're taking. We get these questions now frequently. What about my patients who are taking your products for dry eye or for AMD? Yes, they need those products and they need the doses that we've recommended of those products, but they now have another disease that is compromising their ability to digest, process, and absorb fats. That's why they need an additional gram or more of omega-3 fatty acid in DHA form. So with that, I will conclude and pass it over to Tim Small, who will show you how easy this is to do in your office.
Thank you, Dr. Gross. And again, folks, in the last 5 minutes of the presentation tonight, if you have any questions, now's a good time to go ahead and chat them over. I already see that we have a few that have come in, so feel free to keep them coming. And as soon as I conclude, I'll make sure that I open them up for our presenters to address. So as we conclude the presentation tonight, as Dr. Gross mentioned, very quickly, how you can apply this new solution into your office. The model that PRN offers to all of our physician partners and under which New Retin would fall under the umbrella of is called our Patient Connect program. That's the partnership model that we offer. And it's a unique program in which it's a revenue opportunity, as we mentioned on the screen, that's in a protected channel. What that means is that by recommending any of our products, whether it be New Retin or PRN's Dry Eye Omega Benefits or our macular products, these are products that are exclusive to you, meaning that you're not going to find these products over the counter without our authorization. They can only be recommended or sold by you. So you don't have to worry about competing with any brick or mortar or online retailers. This is something exclusive to you. And one of the main pillars of our business model is that we provide an educational experience to your patients, and that in doing so, we have all the data to prove that by providing that experience, we're able to improve long-term patient compliance across all of the products that are within our portfolio. So your account manager will be following up with you at some point to review what that model is if you're not familiar already. But the bottom line is that our model is perfectly positioned to help you to overcome all of the different threats that are out there in the market today. When you recommend to your patients, not only when it comes to supplements and nutraceuticals, there's a lot of areas and a lot of opportunities and a lot of alternatives that the patients can resort to find poor quality alternatives. And so with PRN's business model, we're able to help you overcome these different cracks that patients end up falling into so you can stay above all of this. Your patients stay connected to your recommendation and they stay connected over the long term, which only means good things for them and it means good things for you and your practice as well. With the impending introduction of PRN's New Retin product into the PRN product portfolio, after doing the data, we find that in our complete portfolio, we're able to address almost 70% of the patients that are walking into your office every single day. 70% of the patients that are able to find benefit from PRN's complete product portfolio. And as opposed to you going around and shopping around for different solutions for different conditions, when it comes to the three main conditions that our products are formulated to address, there's really only one place that you need to go, and we're able to address a majority of those patients that are dealing with them. New Retin, as Dr. Gross just introduced, is going to be rolled out to the market next week, actually, which is pretty exciting because we've been waiting a few months now. And for those of you that are on the webinar tonight, you get early access to the product before any of our other partners do. So as part of that, we want to make sure that you're aware of the pricing that's available for this product. So New Retin's a little bit different from the other products in PRN's portfolio, and that it doesn't come in a bottle. It actually comes in a really cool blister package. It's a 4-week supply, and the wholesale cost per package is $19 per pack. The retail cost to the patient is $34.95. A case of New Retin has 24 packs to it. And as part of your participation in the webinar tonight, as a hopefully early adopter of the new product, we're giving all of you the opportunity to take advantage of a special that we have until the end of March, a buy one, get one offer. And again, for all of you that are on the line, you could have this product in your office as soon as by the end of next week. So this is pretty exciting, and we hope all of you will take advantage of this early offer. As far as the next steps go, in no particular order here, there will be a survey that will follow the webinar. In order to be eligible for the honorarium, we ask that you fill out the survey. There's just a few questions. There will be a follow-up email. It'll contain a number of the clinical resources that we covered tonight that you will be able to use and read over and review. Your account manager, you can expect to follow up with you within the next week or two to set up a lunch and learn so that they can spend some time to go over New Retin in more depth with you and your patient. And again, talk about PRN's unique Patient Connect model and how New Retin fits within it. And then as far as the honorarium goes, this will be either dropped off to you or mailed, depending upon if you have a local account manager within the next couple weeks. So that concludes our presentation for tonight. I'm going to take a look at our questions to see if we have any that are on the board. The first question that we have, actually we have quite a few now that I look at it, so let me get myself organized here. Here's a good question from Dr. Leslie Miller. I'm going to pass this one over to Dr. Feynman. What dose or recommendation are there for the pre-diabetics?
Well, the easy thing about New Retin, the dose is standard. It's the dose in the recommended serving size. So New Retin can be used in pre-diabetics, diabetics with retinopathy, without retinopathy, or even those undergoing treatment for macular edema. So it's standard dose.
Okay. Next question here. Does the EPA and DHA ratio suggested here work for patients
for diabetic patients?
Type 2 diabetics, sorry about that. For type 2 diabetics with evaporative dry eye. Either one of our presenters would like to address that question.
So this question's come up on several webinars now. I would think about these as completely separate products. Each of them is specifically formulated to address a certain need. For the dry eye product, the high EPA to DHA ratio is going to be more effective. The anti-inflammatory effects are more pronounced, and that's going to give you the right form and dose for dry eye. If you have a dry eye patient, which many are, and who also has diabetes, my recommendation would be to continue with the dry eye product, but in addition, add in the New Retin with the high DHA to EPA ratio, the 1 gram of DHA. And that will supplement the dry eye. This is not considered to be too much. This is well within the safe range of omega-3, but you're getting the right form and the right dose for each specific condition. Mike, do you agree with that?
I do, and remember, as I try to emphasize, newly diagnosed diabetics have newly diagnosed lipid compromise. They need an additional amount, in this case DHA, not only because they have dry eye, and that hopefully has been helped with their dry eye product, but they need extra omega-3 now because they have difficulty digesting, processing, and absorbing fats.
Great. Thank you very much. Next question from Dr. Harris. In patients with dyslipidemia, what products besides a purified DHA EPA product would improve absorption into the bloodstream of your products?
Oh,
that's a heck of a question there, Dr. Harris.
I'm not, as an ophthalmologist, retinal specialist, I'm not sure I would be qualified to answer that question. I don't know that there is any lipid absorbing enhancement that can be taken orally. I'm just not sure. Mike, are you aware of anything?
I'll tell you, in 10 years, I don't believe I've ever had that question before. So I'm going to give you a sort of off-the-cuff response based on my nutritional training. Basically, fats themselves help fat absorption.
So take it with a meal.
So if you take it with a meal,
that's probably the best. I agree
Right.
with you.
Okay. All right. Next question from Dr. Allen. Would New Retin be advised for pediatric type 1 diabetic patients?
Of course, all of these studies were done in adults. It depends on the age, but type 1 or type 2, I believe, would benefit. And that's what most of the patients, as I mentioned, with diabetes in the United States are type 2, and that's what this product is generally geared towards. But in the studies looking at diabetic retinopathy, Once you have diabetic retinopathy, I think absolutely increasing the omega-3 in the diet, even for pediatric patients, is not a bad recommendation. I would certainly clear that in a child. I would clear that with the pediatrician just to make sure there's no issues. But in my opinion, omega-3s, eating fish, kids eat fish, adults eat fish. I don't think there's any danger in using this product in children.
Okay. Next question. Some resistant patients mentioned risk of liver damage with omega-3. I have not had a chance to research this, but can you speak to that comment? That's a new one. I don't think we've heard that one yet.
Oh, well, yes, if you hear me taken aback a little bit, actually the opposite is true. Omega-3s now, there are 2 huge studies underway using omega-3s for fatty liver disease. We know that it will help folks who are struggling with that particular problem reduce the fat content of the liver. So I would say the exact opposite is true. And I think maybe Dr. Feynman would have.
Yeah, I think that patients may be confused, which can happen. One of the most common causes of acute liver failure in the United States is actually dietary supplements for weight loss. And a lot of these have impurities, and it is a real issue. But we're obviously not talking about that here, and they may be confused and lumping that into the other category of weight loss products and stimulants. Clearly, that's not the case here. This is a natural product, and there's absolutely no impurities or other additives that would be potentially dangerous. And by the way, there are many supplements out there with a whole lot of mishmash of different components that haven't been proven. And one thing that Mike Gross and I have decided from the beginning is that unless there's a scientific basis for adding any ingredient to our products, you won't see a lot of that mumbo jumbo in any PRN product because all of them potentially have the risk of causing some harm without any proof of doing good.
Staying on the same topic there, well, let me just go to a quick one real quick here, actually, on the dosing. I'm going to address this real quick for Dr. Moon. What is the dosing for Nuretin, I believe, is the question that you're asking, Dr. Moon. It would be 2 capsules per day. And then for Dr. Miller, I'm going to paraphrase your question a little bit, but I think I understand what you're asking. Would the dose for pre-diabetics be the same?
Yeah, I answered already.
Oh, you did, okay.
Yeah, that's the same. 2 people. All right, so maybe I wasn't clear. Pre-diabetics, like I said, it's a continuum. And if you're delaying the onset of diabetes, absolutely, it's just the standard dose.
Dr. Johnson asked more of a business-related question, and I'll address, Is the product also available in mail to the patient like other PRN products? And I understand what you're asking, Dr. Johnson, and it is. In fact, with a product like Nuretin, it's probably even more important than any of our other products that the patient is getting this delivered to their home on a regular basis. This is a long-term therapy that they need to get shipped directly to them. It's very difficult for them to come back to your office on a regular basis to get a product again. That's a 4-week supply. So the easiest way for the patient to receive this on a long-term basis would be to have them to go through our Patient Connect program and have it shipped to their doorstep free of shipping over the long term. Next question. Again, this one is pretty similar to another question that someone had already asked again about what would you recommend for somebody with diabetes and dry eye, especially if cost is a concern? Any difference to the last response to a pretty similar question that we had before?
Well, it's very hard to factor all these things together, and we know the patients are challenged in how expensive medical care is in general. Yes, these are out-of-pocket situations, but if you ask a patient how much money they would spend to prevent the loss of sight, I don't think they could estimate how much money that would be. And that's what we're talking about here. So while dry eye, I'm not an eye expert, I guess it might have some sight-threatening potential, and it certainly interferes with the quality of life. This is something which interferes with life and sight and all of the above. So usually, and what we're finding when we discuss this with patients in our focus groups is that cost is not an issue. So I hope it won't be for you all, because this is a tool that should transcend price.
Thank you, Dr. Gross. And the questions keep coming. This is probably our most responsive audience yet. The next question I'm going to address from Dr. Cohen. Zia Vision has a product for retina health based on a study which includes diabetic retinopathy. Can either of you comment on this study?
I can comment. It's Mitchell Feynman. I know this study very well. This product, actually, let me just start with the study. The study was not designed as a long-term study. It's a snapshot study. So basically, they looked at different parameters, and they put patients on a supplement containing, too numerous to count ingredients in the supplement. And they looked at a variety of different endpoints, such as macular pigment density, color vision, and then some other extraneous things like neuropathy scores, etc. But the problem with this study, and again, I don't know each of the components that are in this product, which include some very strange things like pine bark extract, and so basically what I'm trying to say is that it's almost impossible to dissect out whether any of the individual components are effective or not. And the endpoints used in this study are not the same ones that I would have chosen, but I wasn't involved in this study, such as progression or development of diabetic retinopathy, which is, that product was never intended to, nor has it even been claimed to have any effect on those factors. So this product, New Retin, is to delay the onset or slow the progression of diabetic retinopathy. And it may also enhance treatment in those who are getting treatment for diabetic retinopathy or macular edema. The I Promise product, to my knowledge, has never claimed or been recommended for that particular subset of patients. Having said that, there may be individual components that are beneficial. My biggest issue with that product is that the omega-3 component is approximately 300 milligrams total. And as we've seen from the PREDIMED study, the absolute minimum to see that benefit was 500 milligrams per day. So this is underdosed if your intent is to slow the progression of diabetic retinopathy. And I think that further studies would be needed on that product to see if it has any effect on the progression. You may see some short-term improvements, but there are other issues with that study. For example, they included patients with and without diabetic retinopathy in the study, and they weren't equally distributed between the treatment group and the placebo group. So these are like intrinsic flaws in the study that make it very difficult to really comment on whether it's effective for the absolute indicators that they looked at. But if you want your patient to have a higher macular pigment density, then I recommend the I Promise product. But if you want your patient to slow the progression of diabetic retinopathy and possibly prevent vision loss, then I don't think that's the right product for you, and I think New Retin would be a much more reasonable choice, an effective choice.
Great. Thank you, Dr. Feynman. And just before Tim gets to the next question, again, I don't understand that study very well myself, especially the endpoints, because I'm not a vision specialist. But there is one thing that came out glaringly to me, which is something that we all accept universally as a benchmark, and that is hemoglobin A1C. And that study showed that there was no impact whatsoever on hemoglobin A1C in the folks who use that product. So it's hard for me to comprehend how something that did not impact the basic pathophysiology of the disease would somehow work for a diabetic retinopathy component of that particular.
I agree. So a lot of the conclusions may be true for patients without diabetic retinopathy as well. I think just because you included patients with diabetes in your study doesn't mean you can claim that these improvements or whatever changes you have addressed with your product are unique to the diabetic population. So I don't think that it's specific. I think it was a convenient population to look at, but there was no control group without diabetes to compare to. So we don't even know, and again, I can get into the details of that product, but suffice it to say, it is the study that supports it is quite flawed, and I would use caution when recommending that unless you know each of the components and exactly which ones might be effective. I can tell you with the PRN product, we know exactly what's in it. It's one ingredient, and it's a high DHA EPA omega-3.
I can't resist asking Dr. Feynman another question, because this is kind of a chicken and egg concept, which is, what is the relevance of macular pigment optical density in retinopathies?
Yeah, and this has come up a lot with our AMD series. Macular pigment density can be increased by including certain components in the diet, whether it be lutein, zeaxanthine, mesozeaxanthine, which is converted from lutein in the retina. And we don't know if those levels that are low in patients with AMD or other retinal conditions are low because the retina has a disease. And there's no proof that increasing the density translates into better vision. I still have yet to see a study where you looked at the long-term results of those people supplemented versus those aren't, and correlated macular pigment optical density with a real reduction, statistically significant reduction in either AMD, or now I guess we can add diabetic retinopathy. There is no data, to my knowledge, that shows a randomized clinical trial showing a clinical benefit. You can measure it, but that's great. You have a higher macular pigment density. What does that actually do for you from a visual standpoint? We don't know the answer to that.
All right, great. Well, thank you, Dr. Feynman and Dr. Gross. That's all the time that we have for questions tonight. I do see there are a few more that are on there. Unfortunately, too many for us to get to right now, but what I will do is make sure that they get sent over to our presenters to follow up with you individually to address. Again, as a follow-up, just look out for a short survey. As soon as we conclude the presentation tonight, it'll pop up on your screen. If you don't see it, just respond to the follow-up email that you get tomorrow, which again will contain a number of the clinical resources that we covered tonight. Again, look out for your account manager to follow up with you within the next week or two, and probably within the next 2 weeks, that honorarium will be to you as well. So on behalf of PRN, myself, Dr. Gross, we thank Dr. Feynman for coming out and joining us tonight. The presentation's been recorded. It'll be up on PRN's webinar portal soon, and you can go back and review anything you might have missed. Thank you so much, folks, for joining us tonight, and we hope you have a great rest of your week.